Good afternoon. First, I want to thank Department of Hepatology as well as the CPLD team for making me a part of this very impressive meeting I've been hearing since morning, and I've been very impressed with the kind of standard which has been set by this meeting. I've been asked to speak on difficult to treat autoimmune hepatitis. Before we go to the second line and third line therapy for treating autoimmune hepatitis, we have to understand what is the standard of care. Outline of my talk will be like this. I'll not be dealing with special patient population because it will be dealt by other speakers. The phenotype of autoimmune hepatitis is very important to understand. The presentation can range from asymptomatic cases to ALF-like picture. And this has got bearing on how we stratify these patients so as to manage them and what is the prognostication. If it is acute icteric, they present with only jaundice. If they have acute severe autoimmune hepatitis, they have jaundice as well as coagulopathy. And if they have AIH-related ALF, they have jaundice, coagulopathy, and encephalopathy. And 25% patients are asymptomatic and 20 to 25% present with acute severe autoimmune hepatitis. And what is more important is approximately 50% patients who have acute severe autoimmune hepatitis, they evolve into acute liver failure. So phenotypic presentation has got a relevance regarding the treatment and prognostication. Now, what are the indications of treatment? Indications of treatment are very clear. If enzymes are raised, that is ALT is more than or equal to 3 times the upper limit of normal. If there is advanced fibrosis, which is in the form of hepatitis activity index more than 4, or if there is well-established cirrhosis. These are the indications. Now, there is a subgroup of patients where ALT is less than 3 times the upper limit of normal, minimal fibrosis, no cirrhosis, whether to treat or not. This is a gray area. It will depend upon other factors like age, comorbidities, and patient preference. But whatever said and done, drugs which are available are safe, but not absolutely safe. So we need to be very clear that one group, we are very clear whom to treat, and other group, it's kind of, we have to decide on multiple factors. Now, this story of steroid in autoimmune started with Sheila Sherlock's study published in Gut 1980, where they showed the survival was much better, almost 3 times in treated patients at a follow-up of 10 years as compared to untreated patients. And this has been a recent study from Europe, which showed basically, if you look at patients who have complete biochemical remission, and you see that the fibrosis regresses. On the other hand, patients who do not have biochemical regression, majority of the patients have hepatitis activity index more than 4. So what it means is if you have biochemical remission, then these patients have fibrosis regression also. Now, we need to understand certain endpoints for autoimmune hepatitis treatment. What is complete biochemical response? It is normalization of SGPALT and IgG below upper limit of normal within 6 months of initiation of treatment. Insufficient responses when this is not achieved. Non-response means when ALT does not normalize, does not decrease by 50% at 4 weeks. And remission is histological remission when hepatitis activity index is less than 4. Now, what we have to realize is that autoimmune hepatitis has got an unpredictable course. There are flares and there are remissions. So even if the patient is in remission, we have to make sure that we monitor the remission is in place. And for that, we need to 3 monthly or 6 monthly do enzymes and IgG and look that biochemical remission is persistent. And treatment has to be, for most of the guidelines, 3 years with at least 2 years after biochemical remission, which is very important. And what we have to understand is despite biochemical remission, approximately 50% patients will have significant histological activity on if we do biopsy, which we don't do in most of the cases, but it is seen. Now, corticosteroids have been the standard of care. Question is 1 milligram versus 0.5 milligram. In most of the patients, other than acute severe autoimmune hepatitis or ALF-like picture, 0.5 milligram is as good as 1 milligram per kg. And what you have to realize is that problem with 1 milligram per kg is the degree of osteoporosis shown in the studies is almost 3 times as compared to 0.5 milligram per kg. And azathioprine is not a very good drug to induce remission. Overall, if you look in literature, biochemical remission is seen in around 60 to 80% at 6 months and approximately 90% at 1 year. But what is more important is an acute severe form of autoimmune hepatitis, the response rate is much inferior. Good thing is, long-term studies have shown after a median of 5 years, fibrosis regression has been seen in almost 50% cases. And off-therapy remission after 5 years of biochemical remission has been approximately 20-25%. When we give steroids, the dose and duration and amount will depend upon a number of factors which a patient may have and which is very relevant. If a patient has got morbid obesity, if a patient has got uncontrolled diabetes, if a patient has got uncontrolled hypertension, patient has got osteoporosis, we have to make sure that we give the lowest possible dose of steroid to maintain remission. These are the guideline based how we give therapy. What we have to realize is that it can be induction phase and maintenance phase. We can use a combination therapy of prednisolone with azathioprine, or we can use monotherapy with prednisolone if patient is intolerant. But what you have to realize is when we give steroid monotherapy, complication rates are much higher as compared to combination therapy of prednisolone and azathioprine. In acute severe autoimmune hepatitis, it is a little different ball game. Here, oral conventional therapy may not work. Here, we may need to load them up with methylprednisolone for 3 days and then prednisolone over the next 5 days. What you have to realize is that these patients are sicker, and therefore we need to be more aggressive in treating them and seeing the response early in the course so as to prognosticate whether they will continue with medical therapy or they need to go for enlisting in the transplant program. Budesonide has come as a big relief, especially in patients who show steroid toxicity. It has got high first-pass hepatic metabolism, so less toxicity. But unfortunately, it cannot be used in 1/3 of patients who are cirrhotics. This concept was started by a man study in gastroenterology, which compared prednisolone, azathioprine with budesonide and azathioprine. And what it showed was that budesonide group had got a much lower complication rate, almost half, as compared to prednisolone with azathioprine group. But it's not a perfect drug. This is a study published in 2017, which looked at 60 patients where 30 were where prednisolone side effect was seen and 30 where prednisolone dependency was there. They were switched to budesonide. But if you see the response rate, it was around 55% at 6 months and approximately 70% at 24 months. And unfortunately, 25% of these patients could not maintain remission and they had to be switched back to prednisolone. It's a good drug, but not a perfect replacement for prednisolone. This is a very interesting study which I wanted to put. This is a Denmark study where they looked at 1,700 patients of autoimmune. And what they found at 1 year and 10 years, the mortality risk was 6% and 26% as compared to matched controls, that is general population. And the mortality was 6-fold in first year and almost double later. What is suggested, even if you treat and patients are in remission, these patients are still at a higher risk as compared to general population with liver-related or whole kind of mortality. Coming to severe disease, I want to highlight only one study, Martin study, 120 patients, where steroid was given in 110 patients, and the response rate was 70%. And almost 1/3 of these patients, despite adequate prednisolone therapy, had to undergo for transplant. In acute liver failure, results are much more dismal. These studies show 8 to 15% response to steroid with normalization of ALT and AST. But what you have to realize is that majority of the patients, they do not respond if they're present with ALF phenotype. What are the factors which predict response? Factor which predict response is total bilirubin and INR level at presentation. This is a mainly non-acute severe. What is acute phenotype presentation? If they have acute severe hepatitis or they have ALF, worse prognosis. If they've got a higher grade of encephalopathy, and if you do biopsy, if you go in massive hepatic necrosis, bad prognosis. High MELD score, failure to improve pre-treatment hyperbulimia after 2 weeks, and no improvement in bilirubin, MELD, and prothrombin time on day 7, and 20% increase in prothrombin time at day 3. Last 3 points have come up in patients, especially with severe acute hepatitis, where you don't want to wait for 2 weeks. So as early as day 3 and day 7, you can prognosticate that which patients need to be enlisted in transplant. So therefore, dynamic assessment is important. This is how we monitor the patients when we put them on therapy. We assess them at 4 weeks, look at enzyme and IgG. If ALT has started decreasing, it's a response. If it doesn't go below 50%, patient is not showing response. And then we follow them up for at least 2 years, and more than 2 years of biochemical remission, they can be considered for withdrawal of therapy. Azathioprine is the drug of choice for maintenance. Long-term steroid is not a good option. We try to put these patients on mainly azathioprine therapy. But in patients who are intolerant, we can put them on low-dose prednisolone, 5 to 10 milligrams per day. And what we need to find is that we have to find the optimal dose of azathioprine. So we can go up to 2 to 2.5 milligrams per kg to maintain remission. TPMT testing, both the guidelines say if feasible, it should be done. It is seen around 0.3 to 5%. It is not necessary, but if it is possible, it is good to get it done. If it is found, then we may need to give them prednisolone monotherapy, or we can give low-dose prednisolone with mycophenolate. Relapse is quite common, almost 2/3 relapse within the first year, and the relapse is much higher if we are using combination therapy when you start withdrawing the drug, and the time is much shorter on withdrawing or tapering down the drugs. So relapse is almost universal. When there is a relapse, we need to reintroduce the original regimen, and we have to try and make that regimen steroid-free, with stepping up the azathioprine dose to 2 mg/kg. Now, coming to difficult to treat group, they are of two types: intolerant and insufficient response, seen in around 10 to 20% cases. And if ALT does not normalize by 12 months, there is a 5-fold high risk of dying of liver disease. This is the approach of insufficient response. If there's an insufficient response, if possible, we get a thioguanine estimation. And if it is less than 20, it means there's a problem with adherence. We need to make sure that adequate drug is given. We can step up the dose, and we can even use low-dose allopurinol, which inhibits xanthine oxidase with low-dose azathioprine. If there is still insufficient response, we go to third-line therapy. If thioguanine level is normal, it means that the drug is adequate. So we need to make sure that the diagnosis is correct. Is there any contributing co-founder, like, for example, non-alcoholic steroid hepatitis or hepatitis C or alcohol-related liver disease? We need to intensify the therapy. If there is still insufficient response, we go to third-line drug. If intolerant, then we try a different salt. We use 6-mercaptopurine. If it is intolerant, then we use MMF. Still intolerant, we go to third line. These are the second-line drugs which we commonly use. MMF is a very promising. This is a recent study published in 2022 where they had prednisolone with azathioprine, prednisolone with MMF. And MMF with prednisolone had a much higher complete biochemical response at 12 months. And we were able to withdraw therapy much better in MMF group. And number two, treatment change was needed in only 10% of MMF group versus 40% in azathioprine. So MMF is a very good drug alone or in combination with steroid. This is again the same thing. Mercaptopurine, we have not used it. Small studies which have shown that a reasonable biochemical remission around 68 to 70%, but it has got significant toxicity. Thioguanine, very limited data. When we use third-line therapy, the indication has to be very clear. Number one, despite good adherence, if there is active progressive disease, despite intensive therapy with the first-line drug or second-line drug, and preferably liver biopsy is recommended so as to make sure that there's a need to rule out alternative diagnosis, and need to grade and stage the disease. And patient preference should always be asked for because most of these drugs are toxic. And we need to look at associated comorbidities because many of the drugs have contraindication, which we need to take care of. There's the list of drugs which are come in the third-line therapy. Tacrolimus is a very promising drug, small case series. Response rate has been around 3/4 of these patients show biochemical remission, and histological remission in a small group of patients have shown significant improvement. This is a study which is very interesting where they looked at mycophenolate and tacrolimus as a second-line therapy for patients with autoimmune hepatitis. They had 200 patients, 108, 93. If you look at the graph, both of the drugs worked in patients with group 1, that is where there's a complete response to standard of care. But if you look at the second group, which had not responded to the first-line drug, response rate was much higher with tacrolimus. So tacrolimus is a better replacement than MMF in patients who have not responded to the first-line drug. Cyclosporin, very limited data, old study, good response, 9 patients, but we have not used it, and it can be used only as a salvage therapy. Rituximab has come up as a salvage therapy, small case series, 4 or 5 patients, but significant biochemical improvement and some degree of histological improvement, but very limited data. mTOR inhibitor has been used in post-transplant setting with autoimmune hepatitis. 1 case series of 5 patients, out of which 2 had complete remission at 90 days and 2 had partial response. So very limited data. It's very difficult to say, but most of these drugs are used as a salvage therapy. Adverse events are very common, but with steroids, azathioprine. But what is more important is with second-line and third-line drugs, we have to understand the possible adverse effect, and we need to select patients very carefully which second or third-line drug we need to give. When to stop therapy? Preferably at least 2 years after biochemical remission. And there's a recent study from Europe which looked at that if you have more than 2 years of biochemical remission, and if you look at histological remission, more than 50% patient will have histological remission. And now guidelines say that if ALT is less than half the upper limit of normal, and if IgG is less than 1.2 gram, we can try to stop treatment with strict monitoring post-stoppage therapy. Surveillance is needed in these patients, whether it's portal hypertension, varices, malignancy, both hepatic as well as extrahepatic, and we need to look at concurrent autoimmune diseases, which are possibly seen in 1/3 of the patients. So this is the algorithm. Autoimmune hepatitis, start with standard therapy, response fine. If there is no response, we go to label them as difficult to treat. We step up the first line therapy with stepping up prednisolone and azathioprine. In negative response, we go to second line, whether we use tacrolimus or we use MMF. If there is inadequate response, then we go to stronger drugs in the form of sirolimus or rituximab. So take-home points would be, if there is autoimmune hepatitis with no cirrhosis, budesonide or azathioprine or prednisolone with azathioprine are the first line. If there is cirrhosis, budesonide should not be used. Fulminant autoimmune hepatitis, majority of them do not respond to steroid therapy, and they have got a significant mortality if not considered for transplant. And if there is a treatment failure or intolerance, MMF and tacrolimus are equally good. But what we find is that MMF is much better because it's easier to give, better safety profile. Third line drugs need multidisciplinary approach with strict monitoring because many of these drugs are very toxic. And though treatment may vary between different guidelines, but what we have to realize is treatment of autoimmune hepatitis has to be personalized. We can't put the guidelines in all the patients. Each patient is different. We have to find out what are the factors which are playing a role in that patient and decide treatment accordingly. Thank you.